Hi everybody, Dr. Daniel. Today I'll be talking about triptan side effects. Well, there's 7 triptans. They're all generic and relatively cheap and well covered by insurance. And they're still the go-to best drugs for acute therapy for migraine. And they've changed the whole experience of treating migraine and neurology and headache. There are 3 new drugs out for acute therapy: Rayval, Ubrelvy, and Nurtec. But they're all name brand. They don't work quite as well as triptans. They have a position for persons who take them that have coverage insurance-wise for name brand drugs because they can be expensive, and also for about the 20% of patients who don't respond well to taking triptans. So again, triptans, if taken at onset, can provide a headache-free experience for 80% of persons in about 2 hours. And other drugs that are used are over-the-counter drugs like NSAIDs, Advil, Tylenol, caffeine, etc., and stuff like that. They really don't work very well. And there's really no place in the world for opiate narcotics or butalbital-containing drugs for treatment of migraine. So triptan does have some minor side effects. Most of the time they're not a limiting thing for patients, but they become the world-famous gold standard drugs for treatment of migraine in the last 30 years, and they're still wonderful drugs and the king of the road. But what are the triptan side effects? I'm just going to read this from a list here. Dizziness, an injection site reaction, sedation, vertigo, nausea, vomiting, a flushing sensation, tingling sensation, and an unpleasant taste. Other possible side effects include asthenia, a burning sensation, chest pain or discomfort, neck pain, neck stiffness, numbness, throat irritation, feeling heavy, flushing, pressure feeling. And less common side effects are abdominal or stomach pain, anxiety, blurred vision, changes in patterns, rhythm of speech, chills, confusion, and muscle cramps, and stiffness. So that's a big list. As a practicing neurologist, most things I really would hear would be sedation and maybe a pressure sensation here in the neck and chest. That's the most common thing I heard. So usually these possible triptan side effects don't prevent the use of the drugs. So if I had a patient, I'd given 100 milligrams of sumatriptan, and they came in and said they've got a chest tightness feeling with the drug, I always ask them, well, did it give you your headache? And oftentimes they'll smile and say the headache was gone in an hour or so, something like that. But they had this side effect. And I usually explain it to them that migraine is a disease process that causes vasodilatation of the cerebral arteries. And the triptans are drugs that cause vasoconstriction of the arteries. And they can also cause vasoconstriction of the smooth muscle in the trachea and the esophagus, and that's where the symptoms come from. Many times, just by explaining that to a patient, that it's benign, there's no big deal, they can do okay with it. The other option the doctor has would be to reduce the dose. If I'd given 100 milligrams, I could reduce the dose down to 50 milligrams and see if that works. Also, when triptans first came out, they came out with the highest dose drug available, and it's certainly the king of the hill drug for treating migraine, which is subcutaneous 6 milligram sumatriptan. And that drug works in 10 minutes. It gets a level in your brain of 100 milligrams. And when the oral drugs first came out, it came out at 25 milligrams and then at 50 for adults and then 100 milligrams. It's pretty much the standard dose for treating adults. Occasionally I'd see an old patient back who's taking 25 milligrams for a headache. They're doing well with it, and I just wonder, because that's really kind of a peaty dose nowadays. But again, if someone's having 100 milligrams side effect from sumatriptan, you can drop the dose down to 50 milligrams. That usually takes care of the problem, and hopefully it'll still keep treating migraine well. The other option that one has is the literature and clinical headache practice states that if the doctor changes to one of the other triptans, like if I went from sumatriptan to L-triptan, 60% of the time that drug is going to work well. Well, the other thing the doctor can do is add sumatriptan to one of the triptans, naproxen sodium to the triptan, and that'll work better. And this was found out by Glaxo before their drugs went generic. They had a name brand drug called Trexamet that got through the FDA, which worked better than sumatriptan alone. So what that drug was 85 milligrams of sumatriptan and 500 milligrams of naproxen sodium. And after that, it was found in articles published saying the doctors could add 500 milligrams of naproxen sodium, which is an NSAID, to any of the triptans that work better than the triptan alone. So that's been done well and helps keeps the dose down and helps prevent possible side effects. Now, 4 of the triptans have problems when they're taken with the drugs. These problems are Relpax, or L-triptan, is contraindicated with antifungals, macrolide antibiotics, or protease inhibitors. Maxalt or rizatriptan requires a 50% decreased dose when taken with Inderal or propranolol. Frovatriptan should have a decreased dose when used with birth control pills and Inderal or propranolol. And there was a warning about Zomig or Zomatriptan have a decreased dose problem with Tagamet or cimetidine. That drug's not been taken off the market. There are some general good rules for triptans. You shouldn't take it if you have a personal or family history of coronary artery disease, you have out-of-control hypertension, previous cerebral vascular disease like a TIA or a stroke. You shouldn't take it if you have complicated migraines with long aura attacks. Triptan should not be taken within 24 hours of another triptan. That is, you can't take sumatriptan today at noon and then tonight take Relpax or another drug. You have to wait 24 hours to do that. And you have to wait 24 hours before you take ergotamine. And most folks are not taking the oral ergotamine drugs like Capragod or Migraine anymore. Those are really replaced by the triptans, but DHE has been used. You can't take a triptan within 24 hours of taking DHE. There's also kind of a non-problem that's been coming out through the years is that the FDA has marked all triptans as a warning so that the pharmacist has sent a note to the doctors, and there are millions of faxed reports that come to neurologists and headache doctors' offices through the years stating that triptans have a possible ability to produce a serotonin syndrome, which is a bad outcome neurologic problem with taking with SNRIs or SSRIs for depression, anxiety, or panic disorder. But later that was found to be wrong, and the type of chemical the FDA was looking at was the wrong one, so it's really a non-issue. And so you can take triptans with SNRIs or SRIs, okay. I have a whole blog article on that at drmigraine.com if you want to look at that. It's called Serotonin Syndrome. So thank you very much for listening to this. I hope you like it. Click on like down there and subscribe. God bless all you folks at Migraine. I hope the triptan drugs work well for you, and I will see you again on the next talk.